Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I am Laura Carfing, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends, and welcome to another episode of Breast Cancer Conversations. I am so excited that you guys are here today. Before we jump into today's content, I just want to remind you, if you have not hopped on over to survivingbreastcancer.org/events, please do so. We offer just about 400 programs virtually a year. So whether you are looking for a support group, whether you're living with metastatic breast cancer, whether you're living with inflammatory breast cancer, looking for yoga, meditation, survivorship programs, survivingbreastcancer.org/events is where you'll find all that amazing content. And be sure to subscribe to our weekly newsletter where we are always dropping new information and love right into your inbox every Monday. Today is such an important topic because we hear so much in our breast cancer community about not just managing a cancer diagnosis, but what does this mean for family planning? What does this mean for my fertility? What does this mean if I have children or want to have more children, or if I haven't yet had children? And what does this mean in terms of all of these doctors we have to put in our pockets? I would say when I was diagnosed with breast cancer, not only did I have my oncologist, my surgeon, my radiation oncologist, but then also a team of genetics counselors to help me really understand my makeup of, did I carry a genetic mutation, and kind of understanding like the biology around this tumor and what this meant in terms of my treatment plans and options. So much great stuff to dive into today. I'm excited because Alejandra, you contacted survivingbreastcancer.org because of this amazing research that you are doing. Let's dive into all these great topics. Welcome to the conversation.
My name is Alejandra Bernal. I'm a genetic counseling student at the University of Pittsburgh, and I have been here in Pittsburgh for around 10 years, but in a previous life, I used to work as an embryologist. And so working in fertility, seeing the struggles of patients accessing reproductive technologies, and I work a little bit on pre-implantation genetic diagnosis as well. So I was very aware of all the issues patients have to have the opportunity to build a family. And when I started studying genetic counseling, I wanted to help those patients with the thesis project that is a requirement for graduation. So I wanted to do a project about how patients are informed about the risk of infertility due to the treatments, and if patients are informed about the options to preserve their fertility. And because there have been many studies showing that that is not done successfully yet, much less than it should be. But I wanted to see how genetic counselors could contribute to the process and helping improve outcomes for patients.
Yeah, my name is Melissa Bourdius. I graduated from the University of Pittsburgh Genetic Counseling School in 1997. I spent the first part of my career actually as a prenatal counselor and working with things like the genetics of infertility. And just back then, we were just starting to do things like pre-implantation diagnosis. And so I'm very interested to hear about how Alejandra's project came out. I was a mentor for her when she was doing her cancer rotation. So I'm as anxious to hear about the results as you are. I am currently a hereditary cancer counselor at a major women's hospital in Pittsburgh. And I deal primarily with women who have personal and family histories of breast and ovarian cancer, but we also see multiple other cancers too, and certainly expanding into our understanding of how men can have increased risks for cancers related to hereditary predisposition syndromes. And I've been doing that work for almost 6 years now. And I was very pleased to have Alejandra work with me this year. We had a good time. I hear this story, unfortunately, way too often that, when we meet with our oncologist about cancer, the first thing we want to do is let's get the cancer out. Let's start treatment yesterday, right? I remember sitting there with my doctor and it was literally like, can you come in next week to get your port placed? And the week after that, we're going to start treatment. And it was this whirlwind of me needing to talk to my employer, work with HR, figure out time off, medical leave, all of these things. Well, I just found out I was diagnosed with breast cancer. And
the question was very short about, do you plan on having kids? And actually, if I reflect on this a little bit more, I think the question was, do you have kids? As if I had said yes, then there's no problem. And we will just move on. No question of, would I want more kids? But the question was, do you have kids? I said no, followed by, do you want kids? And I remember turning to my boyfriend, now husband at the time, and I'm like, well, I have cancer. Like, are you cool with just starting treatment? Like, are you cool without kids? Like, should we just move forward? There was really no time to process. And as my boyfriend, it was kind of an awkward conversation anyway. And so it just moved really quickly. And so I would love to hear your experience and, how we can incorporate, well, one, what did you find out during this research? Who did you speak with? And then what can we do to provide more education, not just from the medical side, but also empowering the patients to say, hey, time out. Like, I want to actually figure out what my needs are, what my goals are. And I don't need to rush into getting my port next week. Give me a little bit of time, and making sure that I'm mitigating the risk and not extending too long. But how do we make sure that we're making informed decisions, not without this like time pressure, if you will?
You mentioned two things that are really important. One of those is asking the patient the right questions and involving the patient in their own care and decisions that are going to affect their future. And the second topic that you touched was having the knowledge and making sure it's a multidisciplinary team approaching, having the time to make those decisions. So the guidelines to inform patients about fertility preservation options have been there for years, since 2012. And different organizations, the American Society of Clinical Oncology, the American Society of Reproductive Medicine, they all have been saying all patients that are at risk of having infertility issues should be informed of that risk and should be informed about fertility preservation. There was a big study that was done in 2020 with around 6,000 patients, and they reviewed medical records, and they found only 44% of oncologists, primary physicians, were providing that information. And that's should not be like that. And as you said, they don't have enough time. Big decisions are being made in a very short period of time. So what they have proven is that when they involve different providers and the information not only depends on the oncologist, there are better chances for patients to have that information, because the oncologists have very short time and they are focused on saving your life, and that's the priority. So that's the reason now they are proposing social workers, nurse practitioners, patient navigators, and genetic counselors. That was one of my proposals, because we are already seeing patients. So on my study, we found that only around 60% of patients, they were all patients with breast cancer, were informed of fertility preservation options, and they were all reproductive age women. So that shows that there is a lot to do still. And I found that out of those patients, around 66% met a genetic counselor during the time previous to treatment. So that shows that we are already meeting the patients. And when I asked the question, did you find that appointment with the genetic counselor to be useful? And they said yes. So that was also reassuring to know that genetic counselors are an important provider for patients, and they are helping make decisions. And unfortunately, I found that only 25% of those patients that met with a genetic counselor received some information from the genetic counselor about fertility preservation, because it's usually not a standard, neither on our trainer or standard practice for genetic counselors to be involved in informing about fertility preservation. But I think that's an opportunity, and that was one of the conclusions of my study, that we are one of the providers that are already meeting with these patients. And yes, patients of reproductive age that are affected by cancer, there are less than 10% of all the cancer patients, but they are a higher risk of having one of those hereditary cancer syndromes, and they are at higher risk of having issues with fertility. So I find that we are very well equipped to provide patient guidance. And of course, fertility preservation is not and our scope to explain, but we can provide referrals the same way we refer patients to other services and provide some information. And that was another finding from the study, that patients appreciate having online resources and having materials given to them with information that is tailored to their needs. And that's something that genetic counselors are trained to do as well. So I see all those as promising opportunities to expand the role of genetic counselors. And this study, I must say, was able to happen because of organizations like yours, like Surviving Breast Cancer and other patient support organizations. I wanted to reach out to patients because many studies have been done reviewing medical records. And if the medical record says that the conversation happened, and it's usually very short, as you said, as in your experience, it's just a couple of questions, and that may say the physician considers they talk about fertility preservation and infertility, but it may not fulfill the needs of the patient regarding the amount of information they need to make an informed decision. And there is a lot of bias because, of course, we are humans, so providers also have bias. And there is also one of the findings in our study that single women without children are more likely to receive this information than married women and women over 36 years old. And those are patients that also may want to have children in the future, or at least have the option, because, of course, fertility preservation is an option, it's not the only way to become a parent.
Yes, I love that you said, like, we want to just have options, right? And I feel like I fall into that class. It wasn't like a yes or no, but I wanted to be able to make that choice when I was ready to have that choice. And you also mentioned something really interesting that I wanted to ask a little bit more on. And I'm not sure if you already said the percentage, but it's wonderful that you're already meeting with the patients because they're being referred to genetic counseling if they have a breast cancer diagnosis. But I also hear sometimes that is another area that we need to empower patients to ask, to say, like, hey, should I see a genetic counselor? And also to have their physicians make that referral as well. And so I think we've made strides in more people now saying, like, yes, I want to meet with a genetic counselor. But we're also trying to make sure that not only am I able to meet with them, but is my insurance going to cover the genetic testing that I'm going to need? And there's so many layers of, okay, am I just going to be tested for the BRCA1 and 2? Am I fortunate enough to be covered for a larger panel? And in my case, I was fortunate to be tested for 7 genes. And then most recently, because they found more genes in the last 5 years, I actually went back to have an expanded panel tested, because we know that the genetics is really 10 to 15% of a predisposition to cancer. And my friends are like, well, at least I know, versus the other 80% of like, well, I still don't know why this happened to me. But making sure that people know that these are additional resources as part of your medical care team so that you can make the best informed decision for you. I wanted to ask also, so I did not do any sort of fertility preservation or anything. I just went straight into chemo. So this is actually an area I cannot speak firsthand about. I would love to learn, when you're meeting with a patient, about genetics and fertility. And you also kind of started this conversation off understanding that people might already have challenges with becoming pregnant and conceiving from a genetic perspective as well. Can you unpack that a little bit for me and tell me how genetic counseling kind of dovetails into this fertility preservation?
Yeah, of course. There are several parts of that issue. That's the reason the goal would be to provide comprehensive information. So first thing, yes, ideally genetic counselors should meet patients before they start treatment, but there are not enough genetic counselors. That's one of the issues, access to services. But they have done studies, even if genetic counselors meet after the treatment has started, and patients that survive treatment for cancer, just because of the treatment, they start having issues with infertility. They may reach menopause sooner, or they may have a reduced ovarian reserve. So, and that happens gradually. The things go declining with time. So even after treatment, some patients may be able to preserve fertility if they are not ready to have a child shortly after treatment is finished. So they could preserve eggs or embryos to postpone that decision for later. And the sooner they do after treatment is done, it's better. So that's one thing, timing. Timing is important. The second thing is, and Melissa may talk about that, the risk of passing that increased chance of having one of those hereditary cancer syndromes. That's another factor. And one of the things I remember as a student, something that most patients ask for any type of cancer is like, are my children at risk? That's very important for families. And that's something that is important to consider, because there are ways to use the material that is preserved, either oocytes or sperm or embryos, to do pre-implantation genetic testing. And it's established in the United States, is considered ethical by different professional organizations, even though it's a condition that does not cure 100% of the time. Having one of those genes with a change that increases your chances to get cancer doesn't mean that you will for sure get cancer. But the chances are high enough that they consider it ethical to test embryos to rule out and sort them based on that risk.
Thank you for that. And so I think that's a great segue, Melissa, if you wanted to add to that.
Yeah. So just as a segue, I am very fortunate that I work in a medical center that has very integrated multidisciplinary teams. And often by the time the patient comes to me, they're usually the breast surgeons have started at that point, or the navigation services that are available have discussed with the patient whether or not they're interested in fertility preservation. And so often when I'm seeing someone who's young and I'm kind of working up the case and everything, I will see that mention in there that they've been referred to the reproductive endocrinology department, or they may have already seen them by the time they come to me. So I usually don't have to talk about those kinds of things with patients, and it's certainly not my area of expertise. And Alejandra mentioned that when we think about doing the genetic testing, if we actually find a mutation in one of the genes related to hereditary cancers, we know that that individual, every time they were to have a child, has a 50% chance that they're going to pass on that genetic mutation that gives that increased risk for cancer. And of course, a 50% chance that they would pass on the functional copy that they got from their other parent. The other thing that is a consideration for us, and this is an area where my prenatal counseling colleagues and I sort of share responsibility, is that there are a number of the cancer predisposition genes that also have risks for childhood health difficulties and problems. If both parents happen to carry a mutation in the same gene, there's a 25% chance that they both pass that mutation onto the child. And then the child has a more severe condition. In a lot of cases, what we're talking about is a condition called Fanconi anemia, which can cause early bone marrow failure, some growth problems with the bones in the arms. Sometimes you'll see absent thumbs, short stature, increased risks for early childhood cancers. And so while many patients will come in and they have these concerns about, if I have a mutation in, say, BRCA1 or BRCA2, what does that mean for my daughters going forward, for their risks for breast cancer? And I also have to open that door and say, if you're thinking about having children in the future and doing fertility preservation, if we were to find one of these mutations that is associated with other kinds of childhood conditions, we're now looking at having your partner have carrier testing as well to see if they also carry a mutation in that gene. And then things for pre-implantation diagnosis, potentially not just for one copy of one of these gene mutations, but two copies that then have different implications for a pregnancy and for a child than just adult onset cancers. So it kind of opens that box up a little bit, and unfortunately has one more thing that those patients need to be thinking about. I think that often when patients come to me, we hope that they have at least had a chance to meet with their breast surgeon, but that's not always the case. Every once in a while, we'll get a patient who's been newly diagnosed. They've gotten that phone call from the doctor's office that says, we got your biopsy results and you have, unfortunately, have breast cancer, that sometimes genetics is the first appointment that they have because they're scheduled for a full day of meeting with specialists. And it's hard for genetics to be kind of the first one over the wall because most of these patients, what they're thinking is, and I think, Laura, you understand this, I've just been told that I have cancer. How fast can I get this out of me? And every little twinge and every little ache, you're thinking, what is that tumor doing? Is it growing? Is it spreading? And as a genetic counselor, I can't answer the questions for them about when can you have surgery, what kind of surgery, those kinds of things. And so while it certainly happens often, they've already met with the breast surgeons. They may have seen an oncologist. They may have met with the plastic surgeons. They may have already met with reproductive endocrinology. And they're coming to me with this head full of all of this information. And it's spinning around in there. And we know that if patients are lucky, they've had a chance to have longer appointment times with some of these specialists, but sometimes they haven't because of the demand for these specialists. And so, our genetic counseling sessions we have a nice block of time where we usually have, at least an hour, if not more, to spend with the patients if we need it. All counseling sessions don't take that long, but usually the first thing I like to ask patients is sort of, how are you doing? How are you working through these things? And are there resources that I can help you with? My primary job is to talk about whether there's a concern that you may have inherited a predisposition to develop this cancer. But there are other things that go along with that. Sometimes we'll have patients who have been so overloaded by information at that point in time that they're not prepared to make a decision about having genetic testing. And that we're able to give them that room to say, genetics is not a window that closes. That DNA that you got from your parents is going to stay the same. And sometimes patients will come in and say, I know that I want bilateral mastectomies. My breast surgeon is on board with that. And so having the genetic testing now is not going to change my surgical plans. And so I would prefer to deal with the trauma, really, of the diagnosis and the treatments that go along with it and come back to genetics later. Other people say, yes, this is going to change the decisions that I make about my surgical planning. And so they want that information up front. But it's very important for us to explore with the patients what we see as the value of that information and what they perceive as the value of that information. Genetics is very involved in genetic counseling with what we call shared decision making, and sometimes sort of patient-directed care that the medical professional doesn't always see the importance of this information or the value of this information in the same light as the patient does. And so as genetic counselors, we're trained in the science of the genetics, but we're also trained to pay attention to those psychosocial cues that we get. Are we picking up that the patient may need more emotional support at this point in time? Do they need just the nuts and bolts of things like transportation to the hospital? Do they need help navigating the insurance that goes along with the treatments? And so while we are not licensed therapists, we are trained to pick up on some of those other needs that may not have anything to really do with just doing a blood sample for genetic testing.
The genetics we can't change. We're born with them. But it's also something that we pass on. It's something that we inherited from our family, from our parents. And so I remember for me, when I was getting my genetic testing done, it actually kind of opened up this odd door with my relatives who did not necessarily want to know if I carried a gene or not, because what would this mean for my cousins and their children? And also realizing, if you possibly carrying the burden that you might have this predisposition. But if your kids are so young and under the age of 18, I think it is, they can't be tested to know in advance if they're carrying this gene or not. So you're also kind of living with this burden of, okay, how am I going to have this conversation with my children down the line type of thing. So it's it can weigh very heavily. And so I'm so glad that you're talking about some of the emotional and mental side effects. And I don't want to use like necessarily pros and cons of getting tested, but just understanding what goals are we trying to accomplish with this new information should we decide to go down that path.
And a lot of times, I would say the first piece of information that patients find valuable when we're talking about the genetics of cancer is to discover that, as you mentioned before, it depends some on the type of cancer. When we're thinking about breast cancer, 10% of breast cancers are related to an underlying genetic mutation that gave that person an increased risk to develop cancers. And when there's been so much media coverage with celebrities having prophylactic bilateral mastectomies and talking about the BRCA genes, or the BRCA genes as they're usually called in the media, the public has this perception that much more breast cancer is due to an underlying gene mutation. And so often patients will be surprised when I tell them that most of the time this breast cancer is sporadic, or it could be familial, combinations of shared smaller genetic factors that families have that also are sharing environmental factors, lifestyle factors, and not unlike when you're looking at a family and you see that that heart disease seems to be prevalent in that family. In other families, you can see cancer, but there may not be a single genetic explanation for that. And so first, kind of unpacking, what do we see in that person's either their recent diagnosis or their family history that raises that concern that there could be a hereditary predisposition there? And what are the guidelines that we use when we're thinking about testing? But testing isn't necessarily indicated for every patient who has breast cancer. But when we're thinking about the women who are focusing on the possibility of the need for fertility preservation, most of those women have been diagnosed under the age of 50. And that's one of the key criteria when we see women diagnosed under the age of 50, premenopause. That is automatically a red flag that there could be something hereditary there that gave that woman a higher chance to develop cancer. And so, we're unpacking sort of what are the chances that there could be something hereditary here, and then what are we looking for when we do the testing. And I think, Laura, you've probably heard many people say, I have the BRCA gene, or I'm having a test to see if I have the BRCA gene. And part of our job, too, is to explain that we all have these genes. We want to have these genes because their job is to protect us from developing cancer. We're spinning there for a little bit. Okay. And, these genes, in some ways, they almost work like spell check. They're making sure that our cells are growing appropriately, that our DNA is copied correctly. And the issue arises when there is an error in that gene's information, or what we usually call a mutation. If you look on a lab report, it says pathogenic variant. That's the fancy medical name for it. But that means that these genes can't do their job properly, that they're not able to give us protection against cancer. So we want to have these genes, but we want to make sure that they're working correctly. And we go through what are the genes that have the highest risks. BRCA1 and 2 are the heavy hitters when it comes to hereditary breast cancer. They make up about 50% of hereditary breast cancer. And as you mentioned, Laura, in the time that we discovered BRCA1 and 2, and it's been a little over 30 years now since we've known about those two genes, we have discovered that there are multiple other genes that can explain that diagnosis of breast cancer or the family history of cancer. And each gene is not created equal. So you have genes like BRCA1 and 2 that are called high-risk genes. And that generally means that the risk is greater than 50% for that person to develop a cancer in their lifetime. With BRCA1 and 2, the risks we really are thinking about are female breast cancer and ovarian cancer. But we know that their brothers and their sons can have those increased risks for things like prostate cancer, male breast cancer, and we can see increased risk for pancreatic cancer. And so it isn't just breast cancer. There are also more moderate risk genes as well. So genes that may double the general population risk for breast cancer. So, Laura, you're probably familiar that the general statistic is that 1 in every 8 American women will develop breast cancer. Some of these moderate risk genes, they may double that risk, but they're not giving a 70% lifetime risk for breast cancer that you'd see for something like BRCA. And so being able to talk to the patients about all gene mutations aren't created equal either. They may affect different parts of the body. Some of them are only known to be associated with breast cancer, or maybe only known to be associated with an ovarian cancer. And so, many times people will come in, the information that they have is that the doctor wants them to be tested for the BRCA genes, and letting them know that, number one, most people don't have a genetic mutation that caused their breast cancer and therefore are not really at risk for passing on a mutation to their children. If there is a mutation there, what does that mean for them? What does that mean for their children? It can be very comforting to tell a woman that while she may have a mutation in BRCA1 or BRCA2, her daughters don't really need to start clinical screening with things like breast MRIs until they're 25, that they're not really at risk for these childhood cancers. And because genetic testing is something where we really focus on patient autonomy, allowing a child to reach adulthood to make the decisions for themselves, understanding the implications of if we find this mutation, what does that mean going forward? When does cancer screening start? What does that screening look like? What are the availabilities of things like prophylactic surgeries, medications to reduce risk, and allowing them that ability to have that space. I certainly see daughters and sons of patients that we tested that they turn 18 and they're coming in to see me. And others say, I don't have the space right now. I'm starting college or those kinds of things. And so once I get myself a little more established, then I'll go back to the genetics people to talk about that, and balancing that parent's anxiety for their child with allowing that child to reach the maturity to make decisions for themselves. There are several cancer predisposition syndromes that could have increased risks for childhood cancers. And in those cases, we do refer to usually the pediatric genetic counselors who work in the oncology space with children to do that kind of testing. But most of the time, it's something that can be put away for a little while before that person's children need to unpack that.
Amazing. You touched upon so many important points. And ones that just highlight, I would like to reiterate as well is, yes, everyone carries these genes, right? And so I think when you were saying everyone has the BRCA gene, that's just part of our body, right? But not necessarily that mutation or that, yes, exactly. So I think, demystifying that right off the top is really important. I also think it's great that you're talking about these other types of genes that are lower risk, right? So I think you're alluding to something like, the ATM gene, PEL, CHEK, et cetera. And that list continues to grow as research continues to develop. And so while I don't have a predisposition that we know of to date, I'm just waiting for the science to kind of catch up because, I'm curious, why did this happen, right? And I can see this playing out in two different ways where on one hand, we just want answers. So as devastating as it might be to find out that you carry this gene and you could potentially pass this on, I do hear, well, at least I know why I got breast cancer. There's a tangible thing that we can either blame it on or understand. And then you're on my side, I was phew, don't have it. But then I'm but now what? What else did cause this, right? And so it is this huge mental, kind of opportunity of are we ready to have the information? Once we have the information, how are we going to navigate whatever that information tells us?
Yeah, we certainly have seen families who have very strong histories of breast cancer, and they may have other cancers like ovarian cancer. And they're frustrated when we can't find something because they want that answer. They don't know how to communicate this to their daughters as they grow up and say, we have this risk, but we can't really quantify it. Certainly we have tools, models that allow us to do risk assessment based on things like breast density, and a woman's reproductive cycle when she started, having periods and when she went into menopause and all of those kinds of things that can help predict for us what risks there may be for someone who hasn't had breast cancer based on her personal and her family history. And certainly there are cases where increased screenings, enhanced screening is available to those women, even if they don't have a known family mutation. And the other thing that we've discovered as we continue to learn more, we refine those risks. So we have a better idea of, are there additional cancers that we didn't realize before were associated with it? And even in some cases, we've had genes completely fall off the panels. They were ones that were involved in, you kind of think of it as being like an assembly line that's maybe controlled by the BRCA1 or 2 gene, but it has helper genes. And are some of those helper genes, mutations in those, also increasing the risk for cancer? In some cases, the answer is yes. And some of them were candidate genes that we tested for years that we've now found mutations in those aren't really increase the risk for breast cancer. And so that landscape in genetics is always changing.
One of the questions I wanted to ask you that maybe you can help me demystify is, when I was diagnosed, I feel like everyone asks you like the craziest questions because they're scared that they're going to get cancer too. And so the first thing is like, well, does it run in your family? And I'm like, wait, are you concerned about me or are you concerned about my family? Like they're trying to like find things so that they can relate it to their own personal experience, right? Like, oh, well, you eat a lot of red meat, so of course you got cancer, or, all of the things that you hear some of the funniest stories. But can you help me understand how the genes work coming from like the maternal or paternal side of the family? And as you're kind of putting together this genetic tree, if you will, how does the mom, dad side of things shape a potential disposition for cancer?
Yeah. And a lot of times, I mean, we still hear patients who will come to us and say, that I mentioned that my father's mother had breast cancer and nobody really paid that much attention to it. But I was always worried about it. And so these genes are inherited in families in a pattern that we call autosomal dominant inheritance. So autosomal is a fancy word that means that both men and women have these genes. We know that both men and women can have increased risks for cancer if there's a mutation in one of those genes, and that both men and women can pass these gene mutations on in families. So we all have 2 copies of every gene. So we have 2 copies of BRCA1. We have 2 copies of BRCA2. One of them came from our mother. One of them came from our father. And it only takes a mutation in one of that pair to have that increased risk for cancer, even if the other one is working perfectly fine. So if you have someone who has a mutation, whether they are male or whether they are female, they start out with one working copy and one mutation. And when they go to have a child, there's a 50% chance that they're going to pass the mutation or a 50% chance that they're going to pass on the working copy. It is a coin toss with each pregnancy as to whether the working copy or the mutation or the working copy goes into that sperm or that egg that will then form that child. And so because both men and women share that same ability to pass mutations on in families, it is important that we get dad's side of the family and mom's side of the family. And sometimes we're surprised. We may look at a family history. We're not seeing a whole lot in the way of cancer there. And when the results come back, there's one of the high risk genes like BRCA1 or 2. And you can look at a family history. I mean, if a patient comes in and says, my grandmother had breast cancer when she was 50, but we're not seeing any other cancers on that side of the family. But her father has only brothers. And so while that mutation may be passing onto some of the men in the family, their risks for things like breast cancer are not nearly as high as what you would see for a woman for a couple different reasons. And we have more breast tissue, we have more estrogen, those kinds of things. But men certainly don't have ovaries, and so they're not going to develop ovarian cancer. We may see some increased risks for prostate cancer. Prostate cancer, though, is kind of like men's version of breast cancer. It's fairly common in the general population, and most of the time it's not related to a gene mutation. So sometimes we can look at a family and say, well, you were diagnosed with breast cancer under the age of 50, and that may be the only thing that's really getting you into that box where we're thinking about doing genetic testing. Your test results come back, there's a mutation there, and we're looking at the family and saying, we don't have an explanation for where this came from. And sometimes it's because, if you think about back in a family, if there was the father's father, so the paternal grandfather, and then down to the father and maybe mostly sons in that family, and that's where you hear people say it's skipping generations. They don't skip generations. So if you inherited one from your parent, then they likely got it from a parent behind them and a parent behind them. But depending on the type of cancer risks that's associated with that gene mutation, it may seem like it's hidden in the family because one sex or the other may have higher risks for certain cancers. If it's a gene related to just ovarian cancer, you're not going to see it in the men in the family. But we're really doing an assessment of the patient's family as well and their own personal history. And that's what, allows us to say, based on this certain criteria, how many people in the family have been diagnosed with related cancers on one side of the family. And to say, based on your diagnosis at such and such an age, you certainly meet the clinical guidelines for doing the genetic testing. But at the same time, we're also seeing a lot of people living to older ages who didn't develop cancers. There's lots of women on this side of the family. And so while we don't have a crystal ball, I can't tell you when we draw that blood sample what that result's going to come back as. We can get a little bit of a feeling from looking at the family. And certainly if we have people who haven't been diagnosed with breast cancer, they're coming in to talk about a family history of cancer. We can also look at that family history and say, we're seeing one or two people here with breast cancer in your family. They were diagnosed at older ages. We're not seeing any of those more concerning hereditary cancers like pancreatic cancer or ovarian cancer. And so it's most likely that genetic testing isn't indicated for you, but we can still provide you with a risk assessment based on your personal and family history to give us an idea of what is your chance to develop breast cancer and are enhanced screenings or other care available to you.
Alejandra, if I can turn things back to you as we're kind of wrapping up our deep discussion today on all things genetics. We were talking about oncofertility, I think was a term that you utilized. And so if you could leave our listeners with, you had some recommendations out of your thesis, but what questions should they be empowered to ask their doctors or be thinking about, as our listeners are listening to this episode, what, key tips do you want to leave as takeaways for them?
Sure. Thank you. Thank you for asking that. I think it's very important to patients to feel empowered. And they have done studies showing that even if patients decide not to go through fertility preservation, still having that conversation, it's very healing. And especially for the future, they will not have regrets and frustrations saying, I wish I would have known. Because that definitely affects mental health and quality of life. Just having those regrets and concerns. So it's very important to get good information. So there are places like the Oncofertility Consortium or the Alliance for Fertility Preservation. Worth the Wait is another organization, and there are several organizations that can provide that information. So it's important to ask, what are the chances of my fertility to be affected? Because not all treatments will affect the fertility in the same way. Are those effects something that are permanent, or they are temporal effects? Will I have that fertility again after a while? And what fertility preservations do I have? So basically those questions. It has been shown that when patients are lucky enough to be in an academic center, like Melissa, who works at the University of Pittsburgh Medical Center, they are more likely to receive that information. But cancer happens everywhere, and sadly, the quality of cancer care you receive depends where do you live. There are states that have mandate fertility preservation coverage by the insurance, around 18 states now, increasing number every year, fortunately. So depending on the state where you live, your insurance may cover fertility preservation. So that's something important to know as well.
Wow, that makes me take a deep breath too, to also realize, and I know we can continue. I'm going to invite both of you back to continue the discussion, because you're also bringing up some of these structural and systemic issues that are working actually against us in terms of access to this information. One of the things that I love of what we're doing at survivingbreastcancer.org is that we're a virtual platform. So, I'm very fortunate to be living in Massachusetts, in Boston, having access to some of the best, cancer centers in the world. But what if I didn't? And how do I get this information and this access to be able to feel empowered to ask these questions. And then also, you bring up a lot of great points too about, what my insurance covers, what are the state regulations, and all of these other outside factors that are impacting the fact that we just found out we had cancer, and this is already very overwhelming. And now there are all these other obstacles we have to confront. And so to have both of you on this podcast today, Melissa and Alejandra, has been, I was taking notes over here. I'm sure some of our listeners are too. But just to feel like we have the support and that you are seeing us, you are hearing from the patients that this is a really important topic, and you are advocating in your centers for working with the patients and having that shared decision-making power. So I really appreciate the work that you're doing, the research that you're doing, Alejandra, and I just really appreciate today's dialogue.
Thank you, Laura, for inviting us. It has been a pleasure, and I would provide you with a list of great organizations that have condensed information for patients, so they easily can access that. One of the issues with fertility preservation is the cost. And if you live in a state that is not covered, there are some organizations that provide grants, and it's important to know. So sometimes doctors don't provide information thinking, it's too complex, too expensive, they will not have time to do it, and it's not true. When patients have the information, that's the reason we want to increase fertility preservation awareness, they may be able to make decisions and find resources. It's not easy, but the more you know, the better you can do.
And thank you, Laura, very much for having us on. And I just wanted to put a little bit of a plug in. If there are people in your listening audience who want to meet with genetics, they don't really know where to start. They have questions about either their personal history or their family history. The National Society of Genetic Counselors has the ability to find a genetic counselor close to you. So if their website is nsgc.org, and you can click on Find a Genetic Counselor, and you can say, I want one who's interested in, cancer, who has virtual appointments, how do I contact them, and those kinds of things, if people are interested in that. And the other thing that I wanted to mention is there are really so many wonderful support groups like your organization. And there are also, groups that really focus on people who found out that they have these hereditary cancer predispositions. And so they have support groups for people who talk about, how did I tell my children that there was this mutation in the family? How did I manage things like pre-implantation diagnosis and all of that? And one of the organizations that we often recommend that you probably have heard of is called FORCE. It stands for Facing Our Risk for Cancer Empowered. And they are a phenomenal group for resources for patients, for hooking people up. I had a patient once who was a surgeon herself and in her early 30s. And one of her big concerns was, if I have a mutation in one of these genes and I decide that I want to have bilateral mastectomies, what is that going to do to the musculature and the strength in my upper body? And will I still be able to reach over my patients to perform surgery at the level that I need to? And we were able to find her another person who was 15 years out who had been diagnosed around the same time. And when I had called her to discuss her results, she said to me, that's exactly what I needed. I wanted somebody to be able to tell me that your life can go on.
Well, thank you all. Amazing resources. I will definitely be sure to keep an eye out, Alejandra, for your list and the resources that we talked about today in the podcast. I'll link to in the show notes and the blog that we put together so our listeners can have access to all of that great information. Thank you. And thank you, everyone, for listening to our show. I would like to acknowledge that all of the information on our podcast is from personal experiences and is not a substitute for professional medical advice. You should always contact your medical care team. If you are looking for specific topics or would like to be a guest on our show, please feel free to reach out. My email is laura@survivingbreastcancer.org. Our show is made possible by our nonprofit, survivingbreastcancer.org, and by our incredible donors like yourself. You can hop on over to survivingbreastcancer.org to sign up for our mailing list, make a donation, and explore the 400+ programs we offer each year at survivingbreastcancer.org/events. Until next time, keep on thriving.